this work is pretty much finished. It will be forthcoming soon, which does not mean that there's not a lot of space to improvements or follow-up. So I'm of course interested to let you know what is done, but also to hear a lot from you, because this is just an initial descriptive piece of everything that we could study, throughout the treatment pathway. And I'm really, really interested to discuss more what might be behind what we see with your input. I think I was presented already very well, so I'll continue and I'll start with a summary. It's actually something we do a bit more in economics, that we start immediately telling you what we find in case you get distracted at the end of the presentation. I think first I wanted to highlight, three key aspects of our paper with, our contribution somehow. One is that, well, this first part usually is more for international audiences, because in the Netherlands, everyone knows how good is the data that we have here. But it's the fact that we use CBS microdata, so it's nationwide, rich administrative data. In this case, our main source is specialist treatment records that will allow it to examine these income inequalities along the treatment pathway. Along the treatment pathway means that we are looking beyond access, which I think is really the contribution we bring here. So we'll study 4 different stages of, let's say, the treatment care or the treatment pathway. And the other thing which I think we do differently is that we try, and I think can still quite well compared to the rest of the literature, condition or need. So in this big question of moving from inequalities to actually inequities, I think we do a step further, getting closer to really unfair, unnecessary, avoidable differences by income because of the rich data that we have. So it's not because we came up with anything special, it's really just the data. So those 4 stages that I mentioned here, the green line will be the first treatment record, which is our basis of work. I'll expand on that later. And what we see, well, first we see that there's a negative association between income and baseline severity of the mental health disorder. So when patients present at the start of the treatment, those in lower income will be in a much worse functioning stage. Second, we see that there's first a negative unadjusted association between income and treatment minutes, per which the people in the lower income will get more treatment. But when we adjust for need, and need I didn't specifically say, but we are mostly thinking of diagnosis and the disease severity, the functioning, then we see that this gradient reverses. And actually those in the lowest income are getting a bit less treatment intensity, a bit less treatment minutes. And then I think our main finding is actually on what we define as an outcome of this first record, the 3 here. We see that high-income patients are much more likely, I would say, to improve their functioning by the end of the first treatment record. And last, because this is not the whole treatment pathway, we are focusing mostly on the first record, we also look at whether the patient will get some additional treatment in the next 3 months that follow up to understand a bit what's happening. And then we see that lower income individuals are more likely to get this additional treatment record, but the differences are not that much of a bigger magnitude that will talk to the previous finding. I'll go in more detail later. So why do we want to study this? I think I'll skip a bit the first and 2 bullet points. I don't need, I guess, anymore to argue for the relevance, certainly not here, of studying mental health and mental disorders. The other point is that I think it's quite established in the literature that the need for mental health treatment is concentrated among low socioeconomic status, most vulnerable people more broadly. When we get to discuss healthcare, it's a bit less clear, or there's a bit more different patterns. In several of, let's say, Western OECD countries, I think there's still a bit of a pro-rich access to care. For example, the US will certainly be a case, mostly if we are thinking without, even adjusting, but without adjusting. But I think in cases in systems like the Netherlands, and what we see, although we are not targeting access, also suggests that the system by itself is already quite pro-poor. So if we just take the people that are getting into the healthcare system, there'll be a higher proportion of poor or low-income socioeconomic status people. What I think we know much less about is what happens from the doors onwards, right? After getting to the system. And I think we know much less of it because there's this key challenge of disentangling the role of needs and actual utilization of healthcare. And that part of it is also related to data limitations and being able to measure what's happening along the treatment pathway. So we are addressing a gap in the literature in that sense, because most of the studies are actually only looking at access to mental health care inequalities. When they look at utilization, it's usually based on surveys, quite limited samples, questions like, have you used consultations in the last year, often self-reported, so don't have that much detail along the pathway as we do. And then I guess that most evidence that is out there in terms of treatment inequalities comes actually from RCTs, in which, because there's data on education or socioeconomic status, there's a couple of papers following up meta-analysis and looking at difference in efficacy / effectiveness by the socioeconomic states of the patients. And actually here in this literature, we see that even when patients were randomly allocated to treatment, actually there are differences, both in pharmacological and non-pharmacological treatment. So people in low socioeconomic status will likely improve less when they are treated, regardless of which drug it is, or psychotherapy or counseling whatsoever. But this is in a controlled setting. So I think the other point that is interesting for us is that mostly from the international perspective, the Dutch system is quite often praised for being egalitarian, having universal health insurance, comprehensive in the case of mental health compared to other countries, which I think is pretty much the case, don't take me wrong. But what we don't know is if this greater access to mental health care and this coverage are actually leading the poor individuals to actually better outcomes. That's a bit the question that we are also seeking to answer here in a very initial and descriptive way. Institutional background, I think I'll do it rather quick because I assume that you're more or less familiar, although it's with more the healthcare setting, so something of it might be still helpful. You certainly know that we all have to have health insurance when we live here. You'll also know that there's a predefined package of benefits that we have access to, that we have to pay the deductible, like in physical, or the first X amount of euros that we spend, except in primary care, maternity care, and whatsoever. Still quite also, you will certainly be aware that there's allowances to help people in the low income to cover their premium. In theory, also to cover their deductible, although research shows that people don't really use that money for that much. And then also in terms of the setting, in terms of where people can get mental health support, we have still outside the formal mental health care system, the GP and the mental health nurses. And then within the mental health care system, GGZ, since 2014, there's this basic segment, which is mostly just psychologists and outpatient setting. And then there's a specialist setting, which is what we are covering here in this paper, and still where most of the patients are. So the specialist mental health care, which is the focus of our paper, clinical psychologists, psychiatrists, multidisciplinary teams, supposed to have the most complex patients. If that's the case or not, it's another discussion. Outpatient and inpatient, that's self-employed, I think. Providers more in the basic though, and I guess, at least for the international audience, I like to say that there's a lot of large mental health providers in the Netherlands because that's quite the case compared to other countries. And then they are reimbursed under this case mixed system, the DBCs, and the DBCs, it's actually where our data comes from. It's the origin of our data, is the data that was originally collected, mostly for reimbursement purposes, although they also collect quite a lot of detail, I would say more for management, governance type of information. So the treatment record is supposed to be this green line over here, just to give you a bit of a flavor of how we think through it or what it's supposed to be. It's opened by a practitioner that has to follow certain professional qualifications. In theory, there is one main practitioner that is the person that is responsible for the record / patient. Might happen more or less depending on the providers. There's several phases to it. There's 3 of them where we take the information that we are using. First, the diagnosis. The diagnosis is done according to the DSM-4, and we are we are also interested in the disorder, but also quite a lot in this assessment of the global assessment of functioning, the GAF score. And then there's all the therapeutic activities, which in our case, we will be taking the treatment time, treatment minutes. And then there's the end of the treatment record where we'll be again looking at GAF, because GAF, this functioning score, is collecting those 2 initial and parts of the records. Importantly, the detail about this termination of treatment, because it has some implications. So the record can be closed for several reasons. Let's start with the most obvious one. It's what we call mutual agreement, which is the patient and the physician agree that it's kind of time to conclude the treatment. So in theory, it's a proxy for the treatment was finished. There can also be reasons on the patient side, like for example, the patient drops out or moves house, moves address, and moves provider. On the provider side, which will be mostly referral to other providers, Some records, and we keep them here, are actually short records that are only open to provide intake, or they are finished very soon after the intake, so they don't even get to the diagnosis, or they were actually only open to provide crisis care, and then might be closed because the patient was already on care or something else. Then the last one is actually in the bottom here. Records are also closed for administrative reason, and this is because it's set up in the system that if the record reaches out to 1 year, it has to be closed and one new has to be opened. So it's really like an admin feature and not really a treatment termination. The reason why we still decided to keep this structure and look at only the first records is that from the data and from reports from actually the providers, we understood that although this is supposed to be only an admin thing, it actually has a bit of impact in the treatment follow-up and the treatment flow. So it's not to ignore that the treatment termination also happens for these cases.
Can I ask one thing?
Sure.
Because there is another reason why people actually, even before 364 days, stop, and that's actually finance funds.
Yeah.
If you have it, so all these mental health care institutes, they have a permission from the insurance company to have a short DBC, and they do, and a long, you know exactly what I'm talking about. And unfortunately, many times it is decided by managers which where they are instead of the practitioner. Now, with that, they have to stop the treatments because then the percentage of long DBCs, they have too many long DBCs, and then the mental health care institutes have to pay themselves, and they don't want to do that.
Yeah.
But is this taken into consideration?
So this is the categories we have in the data,
Mhm.
and record closure is a requirement for them to be paid, so they always have to code something. I cannot tell you for sure where the cases that you are reported, but I believe that they will be in principle administrative closures, because in the administrative closures, I have 86%, something like this, that actually have 30-64 days, but I have others that don't. So it could be two things.
So probably it's there.
Yeah. So it could be if the patient is referred to some other provider, then it will be provider side, because that's defined there. Otherwise, I think it will be in the administrative ones.
Nice. Yeah.
Thank you for the comment. So yeah, our data has generally we have this link administrative records, but importantly, which I didn't say yet, we are looking at 11 to 16 just for data availability issues. I can go on that later if you are interested. Most importantly, we have the specialist mental health treatment records, the DBCs. What we will get from there, we could get more, but for the purpose of this study, disorder type coded according to DSM. Fourth, the Global Assessment Functioning Score, GAF, which is also, so it basically is the fifth axis of the diagnosis classification. And they have to collect initial and final, in theory also throughout the treatment, but what we see in our data that it's properly collected, it's the initial and the final one. Telling you a bit more of GAF, I'll show you a bit of the description, but it's rated by the clinician or by the therapist, should more or less capture psychosocial, occupational, and educational functioning altogether, originally from 0 to 100. But in fact, what is defined, and I'll show you, it's 10 points category. So in our data, that's all that we have. We know if the patient is between 0 and 10, 10 and 20. Also, because in any case, that's what's kind of defined, the rest is a bit to the therapist to decide where to place.
And is this one score or are these 3 scores in each of these domains?
No, one score only. I'll show you a bit how they come together. And then from the records, we also get the treatment minutes and direct and indirect. So they code and they register not only the time that they spend with the patient, individually or in group, but also the time that is spent preparing the consultation, traveling, if that's the case, all indirect activities. And then we link this data to 3 other sources, municipality registries. We'll also know here that we have quite pretty much to be registered at an address, and that's usually the source of data that we start from when we are using microdata. And there we'll get age, sex, gender actually, migration background, and we'll get the address of the person. We link it to tax records as well, and here is where we get our main measure of income, which is equivalized disposal household income at the beginning of the year. And then we link it to health insurance claims. In health insurance claims, basically, the insurers report all the costs, expenditure that they cover per category. And in here, we will use it just to help us to select our study population based on past expenditure, which we proxy for past use of mental health care. I'll also tell you a bit more in a bit. So, Gav, to kind of try a bit to answer your question. So this is what is available basically to who is rating. It's just these categories. And then like if I pick one just out of, usually from 70 onwards is what these three up are defined as pretty much functioning normal people, let's say. Normal is not a good word, sorry. But in any case, for example, this category here, you can see should be someone with some mild symptoms, or some difficulty in social, occupational, school functioning. So they cover the three simultaneously, but generally functioning pretty well, and which has some meaningful interpersonal relationships. If we come to the bottom here, 1 to 10, will be someone in persistent danger of severely hurting self or others, or persistent inability to maintain minimal personal hygiene, or serious suicidal act, or with clear expectations of death. So then what we know is if the person is in any of these categories, and we know it in the beginning and in the end of the treatment records. How do we define our study population? Well, that first part there, it was to remind me, in case I didn't explain you, the thing of the 1 year length maximum. I've already done so. But basically in the municipality records, we pick, well, we start from there. So this has to be someone that is registered in the Netherlands. And then we are quite, I think, flexible. We just make that the person has to be living in the Netherlands for 1 month of the whole study time. We don't want to exclude a lot of people because they move or so. We still think it's relevant to have that. Then what we kind of made a choice here was to focus only on first treatment records. And that's pretty much because we want to pick people more or less at the same phase of their pathway through care. We didn't really want to be comparing some people that are starting care now with people that are maybe in the 2nd year of care. Of course, we have some limitations because we don't observe all the life course. So what we do is 2 things. We pick the first treatment record in all our study period, 2011 to 2016. And then we also go to the healthcare claims where we have expenditure. And then we have data before 2011, and we make sure that that first treatment record, that patient did not have any expenditure in the previous year. So that we can kind of more or less have a back period that is more or less equal to everyone in the study period. We also exclude records with 0 treatment minutes because effectively they didn't get to have any treatment, any care. And we exclude records with missing information in our key variables, GAF, treatment minutes as well, and household income. So I actually could have put here, it's not major, to be honest, in our setting, but unfortunately we can only compare a bit these cases. We cannot run our results because they have missing information.
So just for clarification, the 0 treatment minutes, that's people that have been referred but they didn't get any care, for example. So that's interesting as well, though.
Yeah, that they didn't even like start the process. So the intake, for example, is just something you do with the admin managers, I think, and that's not yet coded as minutes. So for example, it might be that those cases.
Or that they were referred and they didn't ever bother to make an appointment.
Yes, or that they just engaged for scheduling the first appointment and they didn't.
Yeah.
Could it also be that the diagnosis is something that is not a category to be treated in mental health care in the Netherlands? So that could be
to be reimbursed. Treated, I think that's all. It's private that people will not pay. That's a very good one. I actually make note to investigate in our information. I don't know if those type of mistakes will happen, that they will be still in the DBC or if they would be taken out. But that's a good point.
Like the adjustments that isn't
Yeah,
insured care.
since our first year it was still, because it's not since 2012, but yeah, I think adjustment disorders will be the biggest one in that sense. Although I think from what I've discussed, because I was quite interested on that, there's a bit of recoding sometimes, depending on your. Okay, so continuing to studying a bit, to show you a bit of our population that we end up after that selection. It's about almost 1 million cases / patients. Is the same. We have only 1 record per patient because it's the first. I've highlighted a couple of things here. I think, well, broadly compared to the Dutch population, we have a bit more of people from either a Western and non-Western background. But I wanted to show you here the distribution on income. The quintiles are designed considering all the population. So we define quintiles based on all the population before any selection. And then what we see is that 30% of our records are actually from individuals in the lowest household income quintile, and only 14% are in the highest one. And it's a really neat gradient of less and less people coming from the highest income quintiles. In terms of disorders, 25% depressive disorders, 18 anxiety, comes down to 8 or less for all the others. I can tell you that substance use, for example, is also 7%. Didn't put it for space. What else? Initial GAF 5.8. It's not, doesn't tell a lot, but I described you the 6, which was still quite functioning, so this will be below. Treatment minutes on average 1,357. Improved functioning tells us a bit more. This is whether you improved by the end of the treatment, so whether you have a higher GAF category than you had initially. 35% of the people do so by the end of the first treatment record. And then, because we are worried that we are just looking at the first treatment record, we look at additional treatment, and then we have 32%. Oh my gosh, what did I do? Sorry, but I'll continue. 32% of the people that have an additional treatment record. So clearly showing that not everyone that does not improve, I think it works like this. Yeah. Clearly showing that not everyone that does not improve is getting an additional treatment. And also not everyone, but actually could be. So we have 44% closed by mutual agreements, have 36 closed by those administrative records from which the majority is 1 year length. 36 is that, well, one could guess that hopefully most of these are in there. We could actually check that, so I have to do that. Methods, what we do is pretty simple. It's just some regression work. We are looking at associations. We use ordinary least squares. We use 4 different outcomes, as I've more or less showed you. So on that side of the regression over there, we will have either what we call the intake assessment. So it's initial GAFs, this initial disease severity. And it's from 1 to 10 in terms of categories. So we will model it continuously as an outcome. We will have the treatment minutes, which is the sum of both the direct inpatient and outpatient time and the indirect treatment minutes as well. This is a highly skewed variable because of some high values. So we do a log transformation of it. It's less nice for interpretation, but we feel more confident because there was a bit of variation that seemed to be driven by outliers when we were just modeling the raw non-transformed variable.
Can I ask a very short question? Sure. What is the rationale behind including the indirect treatment minutes?
Well, the rationale is that actually it's part of everything that the system, let's say, not even to say practitioners, but give to the patient. So I guess it's also time that will contribute to actually the success of the treatment. For example, if it's time that the practitioner spends preparing the sessions.
So it's more than merely administrative.
So it's not. This is not time spent by managers. It's time spent by practitioners, clinicians, or psychologists, or so not admin people. Just the professionals that are providing care. But it's activities that they do in the absence of the patient.
For instance, calling the GP.
Yes.
Yeah, making the notes.
Like the notes, studying more if they need. So
Intervention.
Right.
so it's that. Sorry, it was maybe not clear from my side what it is.
Thank you.
Yeah. And then the third outcome function is improving in the functioning. So here we do a binary variable, which takes the value 1 if the final GAF category was higher than the initial one. And then the additional treatment record is also a binary variable that takes the value 1 when there was 1 additional treatment record in the 3 months that follow up from the record closure. And then on this side of the regression, we have our main explanatory variable, which are the quintiles of income. Just to remind that the definition of adjustable disposable household income, adjusted means that we use the CBS of Statistics Netherlands factors to equivalize, to divide by the number of people in the household. And then in terms of disposable, we have the income net of taxes, social security contributions. Yeah, and that's it. The household I already set the size. In terms of controls, we have what we call baseline covariates. It's mostly demographics by something else. So gender, age, migration background, the 2-digit address postcode. Here a note to say that we use the postcode here, 2-digit level, it's mostly the municipality level. So we're using it more to control for the supply side. We don't think it's picking yes neighborhood type of effects. We wouldn't want that because our measure of income here is a measure of socioeconomic status in the end. So this is mostly for the supply side because of differences in mental health providers within the Netherlands. And then year and months of record opening, and then the diagnosis. Here also I make a stop to say that we try to use it as detailed as possible. So we actually go up to the 3rd level and we have 97 categories of diagnosis that we will use as dummies to allow it to be the most flexible possible to control well. And then this is what we use in all the outcomes in the 4th. Then as we move forward in the treatment pathway, we also control to what was happening before. So treatment time, functioning improvement, and additional record, we control also for the initial severity, the initial GAF. And in terms of when we are looking at the functioning improvement and additional record, we also control for treatment time. We want to try to look at each step adjusting. We also do it without, but our conclusions, we want to be, whether an individual improved, regardless of whether it started in a worse condition and regardless of whether he got more or less treatment minutes.
So you decided to use the improvement of the GAF just binary?
We have a couple of robustness in which we also saw whether people keeping the same or the trio rates. We also use it continuously. I don't think I have the table here, but we modeled a bit. All the others don't tell us a lot.
And the GAF is always filled in by the same clinician, right? Or not?
These are the guidelines. I will not
Okay.
be. I can imagine that some providers will comply better or not. The guideline is that it should be also the main practitioner, which is accountable. How much it is complied by, it's hard to say.
Yeah.
Actually, had a very similar thing that is there's a baseline effect. So if you score 1, well, the chance are you're going to improve. If you score 7, chance are you're going to improve.
I also do. I should have put it here. I also do the results stratifying whether you started at 4, 5, 6, or 7 because it was the ones where we have more people. Don't see a lot of difference. So I see that, but it's not that only people in 4 are for the distributional effects. It doesn't really. We see distribution across. We see inequalities across the whole of it.
And is it diagnosis at what points? Because often people come in with very common, like depression. And then
something else.
You're actually part of treatment is actually to find out what is actually then doing something else. Like for instance, this happens in our clinic for young adults. In majority of the people, right? So do you adapt it after or? So
for this here, I should have said it, it's primary diagnosis and we take what is given to us by the DBC. So it was what they do in the end when they coded, because they also need to say what's the final one. It's what was coded as the primary diagnosis by the provider.
In the beginning.
It might be adapted. I know exactly of what you described, that after 2 or 3 consultations, they might adapt it, as long as they don't terminate the treatment record, because sometimes if they say, okay, this is not what we expected and there's someone else better to treat this in other provider, then they will close the record, is a provider side closure and they refer it. As long as the adaptation does not lead to a new treatment record, we will have what's the final one.
Nice.
Because this is what is in the main source of data. We also have data that codes secondary diagnosis, and we did sensitivity analysis also looking a bit at that, just quite simple in terms of the number, if there was like 1, 2, or 2 or more. 1 additional, 2 additional or more doesn't seem to make a lot of difference in terms of adjusting. Let me just look at time because we are okay. We're okay. So a couple of additional sensitivity analysis where I think I didn't mention the one that I just referred to you, but would show it a bit later. So we try a lot in terms of what we are trying to get here, what we call partial associations. So we are interested in adjusting for a couple of things, but we also try with and without to understand what's going on. We look a bit at the type of disorder to understand whether what we are finding is a system thing or it's driven by certain disorders. And then, because it's, I think, the most maybe tricky part of our setup, we look a bit at the reason of closure to understand, one, if our outcomes are differing a lot by reason of closure, and if the inequalities in the outcomes are differing, and also if there are inequalities in the reason of closure itself, whether poor or rich people will have their treatment records closed more or less by one or the other reason. Yes. So this is just a visual presentation of the results before going into detail, but it's just to show you that the gradients are really like super clear and quite neat. Here from the first to the fifth quintile, lowest to highest income. So people, let's say, okay, people with highest income will start treatment with a higher GAF, so with lower treatment severity. They will have slightly more treatment minutes, although here it's quite flat. They will be much more likely, if you ask me, in terms of to improve, but I'll tell you the magnitude in a bit, and they will be a bit less likely to have an additional treatment record. But in terms of here, it's the same scale. So you see that the gradient in improving is actually much smaller than actually in getting additional treatment. So our concern was like, are we seeing something that then will go out with time because people continue in treatment? I don't think all of this will go out with time or with additional treatment minutes, because we already see that this gradient in additional treatment minutes, additional treatment record, does not completely compensate for those differences over there.
So the highest income, or not?
Yes, so highest income people much more likely to improve.
Yeah, but also much more likely not to get an additional treatment.
A bit, I wouldn't call it much more, but a bit less likely, some percentage points. So here we go from 20 something to 40 something. Here we go from 30 something to just above 30.
Can I ask a question about the additional treatments? Because it's probably not in the records, but I was wondering, also because I know quite a few people who've done this, like more high income people, so after treatment, they don't have additional treatment with an official mental health care provider, but they go to a life coach or something similar. And that doesn't show up in the records, I think.
Yeah, no,
right?
I mean, this is from the payment system. So if this is something they seek out of pocket, and if it's not probably not even, then we are not capturing that at all.
But they already approved for that.
Yeah.
Also,
Much more.
And if you go to a life coach, then obviously your symptoms are not, you know what I mean, like.
no,
You don't need a hardcore.
No, exactly. But as a sort of maintenance kind of.
It's not necessarily.
I think that life coaches can help people.
It's just an acceptable way of seeking.
Well, exactly this. Exactly this. Some
And you
people,
have
also younger people still don't want to go to a psychologist. Or don't want to continue.
But there's also an incredible shortage in the Netherlands. Everyone knows waiting is so long. And when you have a psychologist, you want somebody you click with. So that's also difficult.
Yes.
Good. So let me show you some numbers. And please save all these thoughts for later, because I want to take notes. So here the initial GAF, like this is the raw mean of the first quintile. So just what's the value in the poorest people that then go in our regression will be the reference category. So they are on average 5.5 in terms of gap. It's not very easy to interpret maybe, but what we can see is that it's really like a clear gradient. So when you get to the fifth quintile, these people will have a GAF score that is 0.4 higher than the lowest. So we see this kind of gradient in terms of treatment severity. And here I'm showing you, it's adjusted for all the covariates that I told you and for the diagnosis. I can tell you that putting or taking the diagnosis changes a bit, but not substantially. Then in terms of the treatment minutes, the values itself are logarithm, which is not very helpful. But what we can do is when we have, are using a logarithmic transformation, we can interpret the coefficients as relative changes. So I'll tell you that this value here for the average treatment intensity of the lowest income people corresponds to 1,490 minutes on average that the poorer people will receive. And what we see is that if you are in the second quintile, you get 2.5% more, 2.8 in the third, 2.6%, and actually in the fifth quintile comes a bit back again. and 1.8% more. So these are not huge differences. And I think what's most interesting is the difference is mostly from the lowest to the others, and then is relatively flat and even comes a bit down. I think one more thing in terms of treatment is what I alluded to in the beginning. When we were not adjusting neither for the diagnosis and for the GAF, look at this. Poor people were getting much more treatment when we were not adjusting for need. And then you adjust for need and it reverts. It's the only of our outcomes that it happens. All the others are stable, they don't reverse. Here is it at, it's the difference between equalities and inequities, right? So if we just look at this without adjusting, we'll get a sense that the system is doing it right, at least in terms of the amount of treatments that is providing. When we adjust, we think we are adjusting right quite well, but it's certainly not all, then it already disappears. Then in terms of functioning.
But I don't understand this finding.
Sure.
So, because, sorry, I'm still a bit jet lagged. So
No,
it's me. But so in the low group, low CES group, is there a higher severity or a lower? I forgot.
No, the severity, it's always highest in the low income people.
Yeah. So
Even
if you control for just to
if I control for diagnosis,
for more severe cases, then you do not see a difference on this variable.
so in terms of their severity, I see that poor people are also in worse functioning states.
Yeah.
And the gradient is bigger when I don't control for diagnosis.
Yeah.
When I control for diagnosis, it shrinks a bit, but it's still pretty much there.
Really matter.
No,
So it's
the
an
only
indication that they might get what they need. Because they are more.
no, there
severe.
I was discussing the baseline severity still, because I think that's what you asked me. Now I'll move to discuss the treatment time.
Yeah.
So the treatment time, let's start the other way around. When I only account for the demographics, then I have poor people getting more treatment time. They get more treatment, they get more 4.1% treatment minutes than the second quintile, more 6.3 until actually 12.2. When I go and I include the diagnosis and the initial severity, then this flips and reverts. So when I adjust for
More, but account for the fact that they have more severe, they would have, they actually get to less.
just a bit less, but they get less.
Yeah.
So this, I think this is just an interesting finding to show that really accounting for need is highly important, to the point that it shifts what we see in the system, the disparities, right? In terms of the functioning, was it clear, Claudia, or?
Because I don't still see, if you control for diagnosis, do you then put it in the analysis as the severity of the diagnosis? Is that something different? Because having, for instance, psychosis is more severe than having anxiety. So how do you put it, how do you control it in the analysis?
I put my diagnosis as dummies. So, and I have very detailed data, so I don't stop at the level of psychosis, I come down to the additional specifications. So basically, it has a dummy, it's in regression, is capturing the things that are specific to that group. It's not a quantitative one, it's not judging. I don't tell my regression psychosis is more severe than depression, but I let it capture the commonalities of that characteristic.
I get it. So.
And we don't force any order on it. As putting dummies, we are just saying these people have this condition, this characteristic.
Yeah.
So it's quite flexible in terms of
you have to be careful with the interpretation.
Yeah, because then it would have been interesting to estimate the covariance between the diagnosis and the gap score. Because you are saying actually that they should be correlated. Because certain diagnoses are more severe than others.
Yeah, definitely.
Yeah, I can check that for sure. Yeah.
Because there's also the issue that the gap score is already related, capturing a bit of the socioeconomic state, right? Because of the occupational stuff.
It might be, although in theory, DSM also has an axis for that, where this type of problems, axis 4 is there, and actually it's not bad in the data. I thought it would be worse, where you capture the house environment if you have education problems. So, I mean, certainly this is how bad the person is influenced by the socioeconomic status.
Yeah, no, I know.
Conceptually, in terms of measurement, it's just through the root of people being in worse status, I think. Yeah. Okay, so
there's something in there in the gap that inquires about household income?
No, that is only what I showed you before, those categories, okay?
Occupation and education.
So in that sense, they are,
Yeah,
Or
but
they
it's
do that,
usually
yeah.
related to your mental health condition.
It's your functioning state and how you're functioning.
Because of you having this mental health condition. So if you're always having no job, even before, if you should formally not count it, but of course, half is like everyone is irritated to be there.
Yeah, it's not about, I thought it would be raising a bit more problems in the reviewers, but they were still quite okay. But yeah, it's one of them.
Reliability is not too bad.
Yeah.
By the way, you would expect it. So if therapists are motivated to score the half, then it's very reliable. But if they're really like, lots of administration, then not. But that's like with everything you have to do that.
and you assume that if you have close to 1 million people, that there would be some kind of averaging out of. both.
Yeah.
That's a bit the argument we end up using. I'll go into that in a bit.
It's better than nothing, yeah.
So I'll show you the functioning. So I think this is the key finding. 26% of people in the lowest income quintile improve their GAF by the end of the first treatment record. And then this is where the difference really are coming. 6 percentage points more in the second quintile, up to 70 percentage points more in the highest, right? So people in the highest income quintile, more than 50% like to improve in the end of the treatment. So from 26, let's say, to above 50, it's, or just below 50, sorry, it's quite impressive. This is to say that what I showed you before, playing with the adjustment here does not really matter. So we still prefer the specification where we account for diagnosis, severity, and treatment, but the gradients are there and just a bit bigger, actually, not that much bigger, the gradients when we control for all of this. And then additional records, 36% of the people in the lowest income quintile will have an additional record in the next 3 months. And then those with higher incomes are a bit less likely, but not that much. So in the end, those in the highest income quintile are just 3 percentage points less likely to get an additional record. So close to 30%, not that much. And again, here adjusting or not adjusting doesn't really matter that much for the gradient that we see. We do a bit of exploration by disorder. We did it actually by all disorders, but for the sake of clarity, I'm only showing you 3 of them here. Overall, so yellow is depressive disorders, blue is anxiety, and red personality, and in green, all of the others together, just to have a flavor. I don't think it changes much if you ask me. We see differences in levels, certainly in some disorders, but the gradients itself, except for treatment minutes, which we know that is our less robust, let's say, outcome that changes a bit more. Yeah, here we see that in the other disorders, apparently the lowest income group people actually is getting a bit more of treatment, and these 3 are still more or less what we saw in the overall findings, but still pointing out to be a feature of the system, not of one condition specifically, I guess. And then diving a bit more.
Can I ask you something? There is always, you also have to, at the end of treatment, you have to indicate the DSM code, whether it's remission, partial remission, and so on. Did you also examine that?
I don't think
it is in my DBCs.
Okay.
You always have to do that. Yeah, now we have different systems than the DBC.
But isn't this now after GAF? Because then GAF was removed, because GAF was supposed to give a bit that indication, the final GAF.
No, it's
Okay.
really, you have to say what's the DSM codes after discharge, and there are specific codes, for instance, for depression with partial remission, full remission, and you have that for every.
I don't think there is in the data, to be honest.
Ah.
Or I might have missed
Because
it, but
verify.
sure.
Yeah.
Yeah. That would be
Probably will be the same, but.
No, but yeah. No, I don't think we have it. But I'll double check. So just to show you a bit of how our outcomes vary or not according to the reason of closure, in terms of whether people improve their functioning. Before any inequalities, just to say that as expected, people that finished the record in mutual agreement are the ones that improved the most, 41%. And then by unilateral reasons, so patient or provider side, and then administrative, only 15% of those that have this admin closure will improve. And the least is people that just have this very short care after a crisis episode. And then what we see is that there are pro-rich for every reason. So regardless of the reason of closure, richer people will also be more likely to, will always be more likely to improve. And then when we look at additional treatment, more or less as expected, 75% of those with an admin closure are the ones that get additional treatment, and much less, I guess, in all the other reasons of closure. And here it's not that consistent. So we see proper gradients for mutual agreement and admin closure, which means that when the records are closed for these reasons, then poor people will be more likely to have an additional treatment record. But actually for the records that are closed from the practitioner side, patient side, or after intake, then rich people are more likely to have an additional treatment record, which to me seems a bit of this ability to navigate, push forward, continue, regardless of the way or the reason the record was closed. And then when we actually look at inequalities in the reason of closure itself, we see that basically poor people are likely to, records of poor people are more likely to be closed by all the reasons except mutual agreement. So it also makes sense. Mutual agreement is what we call, like, we expect to be a proxy of completing treatment. And then this is more likely in rich people and less, all the others are more likely in poor people. And these are always very clear gradients. It's not that it jumps, it's always like, so moving to the discussion to give you time to think with me through these findings. I think what we've tried to show with this initial descriptive paper is that once individuals get access to treatment, there are inequalities that have at least potential to harm those that are the most vulnerable in each stage. So they start the treatment with the most severe disease. The lowest income gets at least a bit less of treatment minutes. They are definitely less likely to improve functioning, and they are more likely to need additional treatment. I think why this is kind of also different is because we can actually control for the different diagnoses, for the fact that the poor people start with higher initial severity and have a bit lower treatment intensity. We have all the patients that are being treated following our selection criteria, and compared again to other countries, the fact that we have income that is coming from the tax records is quite good. Like in the UK, most of inequalities work is based on area deprivation measures. So our income measures or our measures of socioeconomic status are quite reliable. We have some considerations or limitations that should be taken in mind when judging our results. One is that we are mostly looking at this first treatment record. So we cannot say that in the longer term, differences would be much maybe smaller, hopefully. There are certainly several criticisms to GAF. The reason why we don't think they are that relevant in our study, well, one is what you more or less already pointed out. It's still the best that we have out there, and one of the measure that was most selected internationally for the longest time, although now it's not anymore. And the second point is that we have the population. So we are, from the perspective of one individual patient, I think it's much more problematic, the type of criticisms. And then that in theory, or hopefully, a lot of it is within therapist assessment. So most of the criticisms, I guess, are also between therapists. And what we are doing is just subtracting initial from final from initial, and hopefully would have been coded by the same person. Just to say that we are not saying much about access to care itself. We are just starting from the beginning of treatment. What we have are associations, and that's actually what we are interested in. We are not here pinpointing that income is causing this. We are just showing that these differences by socioeconomic status are there. And I think a later one that I would mention is that in terms of treatments, we are only capturing minutes, and minutes is just one of the dimensions, right? We would need to know much more to be able to say about quality of care. Still, there's a couple of conclusions that we try to take. I think first, I don't know if early detection is the right way to frame it, you'll tell me maybe, but I think there's a signal here that the system, broadly, not only the healthcare system, but the system should do something better to get low-income people into care at an early phase, or at least that they are not yet in lower functioning, assuming that they are the ones getting there too late and not the higher income people getting there too early. That we don't know. But let's assume that it's actually those that are in lower income that are more delayed. We think that our findings might mean that lower income individuals, they might require more treatment minutes or more treatment courses to get to the same type of outcome. And then in terms of why are we seeing this, I guess it highlights a lot of probably complementarities, right? Between what's the patient side, what's the system, and how they match. So there's certainly things like adherence, ability to continue treatment, financial barriers on the patient side. There's the match between the patient and the practitioner, how the practitioner can decide the treatment if it's appropriate. And bottom line, I think we can also discuss some differences in quality of care that might also be there. But this is just an hypothesis, right? And I think that's it. Happy to have your additional thoughts.
Thank you so much. Question, well, you were already off the slide. Well, that's this question, maybe more.
Some additional thoughts, because when you're talking about the explanations, we're bringing it very much down to the quality of care, right? And looking at from the care and looking at the social environment, maybe.
I think the interaction, honestly,
Yeah, but
between.
but I also wonder if the structural conditions in which those lower income people living in, like the stresses of everyday life and all that kind of thing, has an impact as well. And so when I have your presentation, I think fantastic work, by the way, really impressive what you've done. Says a lot, but I wonder if when you're interpreting or discussing that you need to consider what you can't measure in terms of the conditions in which lower socioeconomic people live in. And so the fact that and why is treatment less successful, communication styles, because those professionals, they're high educated professionals versus, so do you these kinds of aspects of treatment, why it doesn't seem to work, but also the fact that it's not just the treatment that might have failed, but the conditions around the treatment, the individual therapists can't change the conditions in which people live in.
Yeah.
So just to say very quickly that what you're just referring in terms of communication style, identification, peer, etc., it's what I'm calling the interaction.
Yeah.
I don't think we can blame either the patient or the practitioner, it's just how it is, and we can try to improve it. So that's the interaction. And then about the structural, so let's be clear, I would never expect these differences not to exist at all, because I don't think healthcare can take care of everything that is happening. Hopefully the system would be able to, I'm using the system today as, but we need to act on all the social determinants. So still, I think these differences are bigger than what we would expect. And most of all, for me, this is really a call for, we cannot stop at access. Granting access to everyone, equal access is very important. We have to keep trying to understand what's going on after, because bottom line, the gap is even widening, at least after initial care. But definitely, and I think now it's proofreading, so I'm not adding it more to the paper, but hopefully in the paper, we argue a bit better than what I did here, that is more than healthcare.
Very interesting, so like, what would be the next step? And it could be on both sides also, right? So it could be that some of the healthcare providers said, oh my God, this is one of those hopeless cases. So let's not put too much effort into it. Or the other side, that these people who come in think, well, this is really not for me, right? This is more highbrow type of treatment. So do you have any idea on whether like cognitions or stereotypes or stigma plays a role on both sides, and then what can you do with it?
There are still some things that can be done quantitatively, because the DBCs offer a bit more of detail on the type of treatment, for example, pharmacological or not. But to dive into those questions, we would have to go on mixed methods type of work and quantitative work. That would be, if I would have the time, I would set up a project now around that. Definitely, I think it has to be. And there's no one single study that will be able to show what's behind here. It would have to be, I think, a big program of work. But for example, we know how stigma is not necessarily so easy even to capture in measures.
A question is literacy also in the CBS data, some measure on the extent to which people are literate or not. I'm sure it correlates with income. But I was wondering about this, especially because you also said, well, you have access, but well, I think it's also important that you can have access, and we have in the Netherlands. But a friend of mine, she's GP, and she noticed that not everyone makes use of having this access. And one factor that might be interesting for further research, that's probably not in the CBS data, but if you're able and willing to advocate for yourself. So in order to get in for a specialist at a hospital, but also mental health care, you need to present your case.
Yeah.
And I think this depends in part on how literate you are, because maybe you want to look up things on the internet beforehand. And well, it's a long story, but I was thinking about this angle for maybe for a future research project, but maybe then you would have to go beyond the CBS data.
Yeah, I mean, there will be in the more survey type of data sets that we have there. So the monitor, the monitoring, so the survey that is done each year, or the one that is done each 4 years. I think there will be some measures around that. But then it's only a small group of the population. So the intersection with those taking care will be much smaller. But they might provide, or the lifestyle one, there's also a lifestyle monitor, maybe has some hints on literacy. And then the other classic one would be the education. There is education data. It's not for everyone. So the education data in CBS is only good after a certain cohort. But I guess also eventually, but that would be still very raw to understand the mechanism that we are discussing.
Yeah. I also think the zero treatment minutes might give some insight, because even though it's a relatively small percentage, it's quite a large number. And so the people that have 0 minutes, even if when they had referral, it would be interesting to see how many of those people have zero, what the underlying is for those 0 minutes.
I can look better. The problem is all of these that we don't capture them is that they are very poor. So I will know their I know the basics, but then often they also have missing treatment, missing diagnosis, and so I did characterize them, but yeah, just the basics. And then of course there are differences. There will be more like a low income and so. So yeah, we are. That's why I'm saying like we are only here capturing like the moment onwards. So I'm missing a couple of people. Yeah.
Can I say? Yeah, it's really excellent talk and very, very fascinating data. And I really like that you stick to the big data, because then you see the large patterns, right? And there are so many explanations. I was just thinking, just to be sure. So if you're at a GP and the GP advises you to not to go mental health care, but to have a talk with what is it? UMH, the nurse practitioner and the AOH, then it's not in here. And this system was a big system change in the Netherlands. I think it was about 14 years. And I would predict that low SES people have a higher chance to not get referred in time to mental health care, but that they actually stick to this POH, which is actually someone with not a lot of training and expertise. So that could be also an explanation that when they enter mental health care, they are more severe, and it's also harder to tackle it.
But for sure that group, but you didn't see that with the death. Oh, you did see that with the death, actually.
Yes.
Yeah. So when I ask, I'm not sure if for the practice side, they will take more time to be referred, because in theory, the POH should only provide about, it changes, but I think at the moment, like about 8 consultations, and they have quite a limited scope. What I know also because of other piece of work is that actually will be on the patient side, because not only because of
the POH, this is the paperwork that they do, but I supervised many POHs and I did some studies with them, and they see many patients for a very long time.
Yes, true, but what I was saying is that not only the supply or the practice side, but also the patient itself. First, because of stigma, so they might prefer to stay just in the GP. It's not actually being in specialist care, but also because you don't have to pay deductible, right?
Yes,
so
that also
they
changed.
When I talked to
when that changed, so previously they didn't have to pay. They didn't have to pay the eigen bijdrage. It changed at a certain moment, so that could be a criticism, like that you can compare that.
That's There's a couple, I can send you, there's
Yeah.
certainly some work around the co-payments itself by one of my co-authors, Bastian Havenstein. And I've done myself on the increase of the deductible, specifically at the transition from youth to adulthood. So the mental health nurses itself, for primary care, you then never pay deductible, which is the
Yeah.
physical, and you also have, there's
Yeah,
also no
yeah.
co-payments. So there, I think it's still a huge, the fact that you have to pay nothing literally to be at the GP and the mental health nurse and everything else you have to pay, I think it's definitely a big barrier. The variation that you were referring to, applies more to the basis, which had co-payments until 14 and specialists until 13. Especially it was only in 2012. We were a bit worried with that in our study, because it can change the people that get to mostly 2011, 12, which was where the year, you might have reminded where there were really high co-payments. So we do some tests taking out that year. We also have year fixed effects. So for this, for the big picture, it doesn't really change, but indeed, mostly from GP onwards, I think that will be.
Yeah, and that's also a preventative intervention. Simply instruct the GP and POH that even in this group where there are far more stressors, because how do you pay your rent and all kind of things, that even there it makes sense to refer in time to mental health care. Because even in time of stressors, this kind of treatment can help.
So you think that it will be actually the issue? So you think from what your experience, then the GPs and the mental health nurses will have the same approach that we were discussing, that if lost cases, that there's no point in referring?
Yeah, I think so. They think, we have to difficult life.
Sounds like
life issues.
possible follow-up research, maybe further discussion. I think we need to, definitely thought-provoking.
Oh, yes, definitely.
Yeah, that's the, it's not a
that's
paper
great,
freelance.
Oh, it's
It's open, yes, but hopefully it's open.
Well, and a robust relationship, I think, everyone sensitively had it too. They're reasonable.
Yeah, they're.
And then, there is a signal, and that is, of course, the question is,